Mhm.
Okay, hello everyone, and thank you so much for joining us this evening for our 2022 Community Health Education Series. My name is Ivania Covington, and I am the Community Partnership Coordinator for Faith-Based Partnerships and Senior Strategies in the Social Responsibility Department here at Baptist Health. Tonight, our topic is colorectal cancer awareness because March is National Colorectal Cancer Awareness Month. We have two esteemed guest speakers this evening who I will be introducing in just a moment. But first, I would like to review a couple of things on our agenda. So we will review a few housekeeping items. We will have the presentation and the Q&A. And finally, we will end with some brief closing announcements. So as it relates to our housekeeping items, tonight's session will be recorded and we will make it available to all of our registrants after tonight. Secondly, we are tracking attendance. And so I know that registration was required to attend tonight's session. So we ask that if we have any groups viewing from one screen on tonight, we just ask that you please just type the total number of participants in the chat so we can track that attendance. And thirdly, my director, Lynn Sherman, will be monitoring the chat during the presentation. So feel free to type your questions there and they will be addressed during the Q&A segment. So just a few interesting statistical facts relating to colorectal cancer that I wanted to share. That when colorectal cancer is found at an early stage before it is spread, the survival rate is about 90% according to the American Cancer Society. But unfortunately, only 40% of colorectal cancers are found at this early stage. Also, African Americans are about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most other groups. So this is why tonight's session is so important and imperative for us to share this information with you. So without further ado, I would like to introduce our speakers for this evening. So first, we have Dr. Vikram Gopal. Dr. Gopal is a board-certified gastroenterologist and internist at the Borland Groover Clinic and a member of the faculty at Baptist MD Anderson Cancer Center. This Jacksonville native earned a doctorate of medicine from Emory University, where he is a member of the school's Hall of Fame. He is a board member of the Borland Groover Clinic and has served on the boards of the American Cancer Society and the American Heart Association. Next, we have Dr. Ron G. Landman. Dr. Landman is a world-renowned expert and invited speaker in robotic surgery for colorectal diseases, specializing in the latest minimally invasive techniques for better patient outcomes and sphincter preservation. He is the foremost leader in colorectal surgery for cancer and IBD in the North Florida and South Georgia region. He's previously served as consultant and specialty counsel site director for colorectal surgery at Mayo Clinic, Florida from 2008 to 2018. He serves on the executive committee of the National Accreditation Program for Rectal Cancer, and he is also a chair of the American Society of Colon and Rectal Surgeons Rectal Cancer Coordinating Committee. So as you can see, we have a wealth of knowledge and experience in our two guest speakers tonight. And so Dr. Gopal, if you're ready, you're up first.
Okay, thank you. I'd like to thank you, Zavon, and thank you, Ms. Sherman, for inviting me here. It is a pleasure to be with you this evening on behalf of Baptist Health and Community Education. Today, we're going to talk about colon cancer. Colon cancer is very prevalent in our world. It is something that Americans face a large burden. 1 in 20 Americans in their lifetime will get colon cancer. Approximately 150,000 Americans are diagnosed each year with colon cancer. And what's even more sad, and we'll talk about treatment options with Dr. Landman later, diagnosing colon cancer early the survival rate is much better as diagnosing it later. Approximately 50,000 Americans die every year of colon cancer. Okay, next slide, please. So the colon is our large intestine. It has a variety of roles. It serves as a storage, digestive tubular structure. It also pulls water out of our stool and allows us to keep hydrated. And there's a schematic of the rectum, the sigmoid colon, descending colon, transverse colon, ascending colon, and the appendix. There's that little finger-like projection. Next slide. So what are the symptoms of colon cancer? Well, they are, some symptoms do not arise until later on in life. So you have to understand the disease progression. Early colon cancer, you may not have any symptoms. As it gets more advanced, you'll have changes in the caliber of your stool. You can have blood in your stool, significant abdominal pain, weight loss, and weakness and anemia. Next slide. So really, we do not know what causes colon cancer. I tell my patients it is part genetic and part environment. And each of those play a role in, unfortunately, why people get colon cancer. So these are risk factors. Risk factors include family history. Next slide, it'll actually tell us the risk factors. Yeah, risk factors. Advanced age, over the age of 50. If you've had exposure or the disease, inflammatory bowel disease, which is like Crohn's disease and ulcerative colitis. If you have a family member with colon polyps or colon cancer. African Americans are a higher risk of getting colon cancer. Being overweight, diabetes, smoking, alcohol, and inactivity are other causes of or risk factors for colon cancer. Next slide. So once again, why are African Americans at greater risk? It's still unknown. It is part genetic, it is part environment. And a few years ago, the American College of Gastroenterology recommended all African Americans at age 45 come in for screening earlier because of the disparity and the higher risk of mortality from colon cancer. Now, the American College of Gastroenterology has recommended everyone get a colonoscopy at age 45 sooner if you have a family history or other risk factors. Next slide, please. So as I said, we talked about them. Symptoms, usually an advanced disease. You have the bleeding, the weight loss, anemia, change in bowel habits. Next slide. So what are the different screening techniques? And we'll talk about this a little further. These are the different risks here that we talked about earlier. Next slide. So there's a nice little colon polyp right there in slide A. As you can see, a hot snare was placed around that colon polyp. The rest of the colon looks healthy. There's nice pink vasculature. It looks healthy. The hot snare then removes that polyp, and you can see the base of that polyp in B. So that is a colonoscopy. The other tests that you can get are stool-based tests. One is the fecal occult blood testing that's recommended yearly. The number 2 is FIT, the fecal immunochemical test, which is also recommended yearly. The Cologuard, which is recommended every 3 years, and you see a lot of commercials for Cologuard on TV now. What are the visualized tests? There is the CT colonography that's recommended every 5 years. It reconstructs your colon through imaging and still needs a bowel prep for the CT colonography. The other one is a visual colonoscopy, a colonoscopy that is performed by a gastroenterologist with a camera, a scope, and the tools to remove those polyps. If you have a normal colonoscopy and no risk factors, you can go every 10 years. Next slide. Here are the sensitivity results of a variety of different things. You can see here, optical colonoscopy in green, Cologuard in light blue, and in, I think, aqua, the fecal immunochemical test. As you can see here, to identify cancer, colon cancer is the highest at 97%, where the other two are trailing. But you get into significant disparities when you look at looking at high-grade dysplasia and sensitivity. These are polyps that have a high potential to turn into colon cancer. You see that the sensitivity drops significantly with Cologuard and FIT. And then for having your regular garden variety adenoma, the detection rate is a lot lower with Cologuard and the fecal immunochemical test, whereas a colonoscopy, which is performed optically, you're looking at a monitor, it has a 97% sensitivity in all three categories. Next slide, please. So how do you try to identify and try to prevent death? Is by recommending each and every one of you get colonoscopies starting at age 45. And it is very important that we talk to our family members, talk to our doctors about colon cancer screening, and educate each other, and especially working towards the African-American population, because the outcomes are not as good as the general population. Next slide. So the whole experience is required to do a colonoscopy is drinking that dreaded bowel prep. It isn't that bad. It does allow you to flush all the stool and mucus out of your colon to allow your doctor to get a good look and make sure that there are no polyps. It does take about 20 to 60 minutes, and the follow-up will discuss, depending on the pathology, when you come back for your next colonoscopy. Next slide. Here are some pictures of other polyps. Number one is a hyperplastic polyp that has no potential to become colon cancer, and they're usually found in the sigmoid colon. You see these inflammatory polyps in two, usually from Crohn's disease and also colitis. They also do not have a potential for colon cancer. You have the third type of polyp, well, it's not a polyp, the protrusion there, that protruding lesion is a lipoma. It could also be a fibroma or a gyst. So when doing a CT colonography, these lesions can show and could be concerning for actually a precancerous polyp. And we'll go to the next slide. Next slide here, you can see other polyps, and you can see these are genetic syndromes that put you at higher risk: hamartomas, juvenile polyposis syndrome, Peutz-Jeghers syndrome, and Cronkite-Candida syndrome that have higher risk of developing colon cancer. Next slide. And these are the polyps that, as gastroenterologists, we like to remove. And these are the polyps that have the potential to become colon cancer. The top is a serrated adenoma. They're usually very flat. They have sometimes a mucus cap on them. And these two are on the bottom are very advanced polyps. You hopefully want to get them small when they're like pea size, but these are very advanced polyps, and these have a significant cancer potential. Next slide. Here's just a video of showing a large polyp being raised and removed by a colonoscopy. And it can just show you the technique of lifting that flat lesion and then removing it with a snare and then sealing that out and hopefully avoiding surgery and waiting for the pathology to come back. You can go to the next slide. So as we finish here, you do not know if you have significant issues until you get a colonoscopy or some type of test. And once again, there could be no symptoms if you have colon cancer until it's very advanced. There's stool testing, there's colonoscopies, there are CT colonoscopy. So think about all these. I think that the colonoscopy is the best option. It gives you the best results and the longest period in between testing. So please get screened, and hope to see all of you talk to your doctor about colon cancer screening. Next slide. I think we're done.
Yep.
Thank you.
We are done. Thank you so much. Thank you so much, Dr. Gopal. Next, we have Dr. Landman. So Dr. Landman, whenever you are ready, I will start your slides.
Thank you again, Zavani. I really appreciate this opportunity to talk to our community here in Jacksonville in Northeast Florida on a topic that's very near and dear to all of our hearts. And that is, at this point, treating colorectal cancer. Next slide, please. I do have some disclosures, but none relevant to this particular presentation. Next slide. So first I want to start off and say that, just like Dr. Gopal had mentioned, that surveillance colonoscopy is absolutely critical. most colorectal cancers have no symptoms at all. That's why we recommend what's called surveillance or screening colonoscopy, because patients don't know they have symptoms. They don't know they're bleeding. They don't have any issues with their bowel movements or abdominal pain. Most cancers are unfortunately identified that way, and most polyps are also identified on standard routine screening colonoscopies. So if you don't remember any of the talk that I give, hopefully you remember a lot of what Dr. Gopal said, but if you remember nothing about what I say, please get screened with a colonoscopy, because unlike most other tests for other types of cancers, colonoscopy has been one of the only screening tests that have been shown to actually cure cancer and increase survival. So that's incredible. However, having said that, let's say you do get diagnosed with a cancer or a large polyp that's not resectable with colonoscopy. It's fortunate that now we have improved medical and surgical care for colorectal cancer. It's now better, it's less invasive, and in many cases, patients can go home either the same day or the next day. But again, remember, get your colonoscopy and avoid me. So next slide, please. So you're diagnosed with a big C cancer. It's not a death sentence. What I want to emphasize, and what all of us want to emphasize, is that we have, teams of physicians and surgeons ready to care for you. When you do get diagnosed with a colorectal cancer, it's imperative that you seek expert surgical care at a multidisciplinary cancer-focused center such as Baptist MD Anderson Cancer Center, and not just the first person who's available that treats anything and everything. Again, surgery is now less invasive and better, and even the additional treatments that we may use or that you may need are less invasive, are more effective, and have fewer side effects. And it's important to emphasize that the multidisciplinary approach to management of colorectal cancer minimizes intervention, yet improves survival and also the quality of life. Next slide, please. So how about operations for colon cancer and rectal cancer? Well, no one wants one, and believe me, even though I'm a surgeon and I love helping patients and I love surgery, we're on your side. And if there's any way we can minimize surgery or even avoid surgery, we are actually advocates for that. We reserve surgery for times when no other endoscopic techniques or other less invasive modalities, including combinations of chemotherapy and radiation therapy, are available. We emphasize a personalized and individualized approach to each and every single one patient. No two patients are alike, not even if they're twins, both diagnosed with colon cancer. We emphasize that each person is unique and tailor that intervention in those modalities to the individual patient. These operations are very complex with the goal of improving quality of care and also cure. You can't have one without the other. Next slide. So again, it's a multidisciplinary approach that we practice here at Baptist MD Anderson to the management of your unique colon and rectal cancer. We collaborate with our gastrointestinal colleagues, our medical and radiation oncologists, our geneticists, and other parts of the team, including pathology and radiology. We have multiple tools in our toolbox, and again, we individualize our treatment to the patient, their disease, and their particular stage, focusing not just on cure, not just on survival, but indeed patient outcomes and satisfaction and their long-term quality of life. It doesn't matter if you're cured of cancer, if you can't be there to enjoy these unique individual moments in your life, including weddings, graduations, etc. That's the whole purpose why we're here. So you can enjoy these life moments. Next slide. And how do you pick a surgeon and how do you pick a cancer center? Well, you want to go to a surgeon in a cancer center that really has a high volume of these operations, particularly for cancer, that emphasize a multidisciplinary approach, particularly a minimally invasive approach. What that translates into is a higher short and long-term outcomes and improvement. It also translates into improved sphincter preservation rates, which means you can go to the bathroom sitting down in a toilet rather than having a permanent bag or a stoma, which also means to lower costs, not just for insurance, but also out-of-pocket costs as well for the patient and the families, less time out of work for both the patient and the family supporting that patient, but also an improvement in survival, particularly oncological or cancer outcomes, and improved quality of life. Specialization matters in management of colon and rectal cancer, and subspecialization, meaning focusing on cancer in colorectal surgery, matters even more. Next slide. What we do when we're as specialists in colorectal surgeons focusing on cancer within colorectal surgical specialties is we always perform complete mesocolic excisions, which improves the ability to remove all the lymph nodes within the surgical bed. We dissect off of the superior mesenteric fat vessels to really get the best outcomes in terms of the lymph node harvest. This translates into improved local regional survival and lower recurrence rates of those cancers. When we talk about rectal cancer, we do a complete, what's called a total mesorectal excision, really removing the entire bed of the rectum and the lymph nodes and the packet encompassing the rectum, which translates into both lower recurrence rates locally and also distant, and improved survival. Furthermore, by incorporating robotics into that modality, we have the ability to improve dissection, improve sphincter preservation rates, and reduce the rate of permanent bags while maximizing quality of life. Next slide, please. We'll talk about some surgical modalities quickly. There's the traditional and open technique, which is still being practiced in Northeast Florida, even at major centers in Northeast Florida. There's the laparoscopic or keyhole. Sometimes people call it laser technique, but it's not laser, it's just laparoscopic. And what we practice here at Baptist MD Anderson for our patients is a robotic or computer-aided laparoscopic technique. What that does is it improves the ability to dissect better, get better resection margins, which also translates into lower pain. Many patients go home on just Tylenol, acetaminophen and ibuprofen without the need for narcotics. Shorter hospital stay. We have some patients going home the same day of surgery, if not the next day, with just one night. Quicker return to work or home. So that translates into lower cost, lower time spent out of work. And frankly, it's just better surgery, better cancer outcomes. Next slide. So this allows us to translate some patients who would traditionally be offered what's called an abdominal perineal resection, or an APR on the right, where we have to remove the rectum and anus and give patients a permanent bag. And we can translate that in certain cases, we're using a multimodal approach and incorporating the robot into a low anterior resection where we can actually remove the entirety of the rectum, but then connect the upper colon to the anus, and therefore allow patients to eventually go to the bathroom in the traditional fashion, sitting on the toilet, and without the need for a permanent bag. Next slide, please. The traditional approach involves an incision going all the way up and down, or a vertical incision up and down, or maybe even on the lower aspect of the umbilicus down to the lower midline. Next slide. Then we've gone to laparoscopy with a couple of little incisions, single port laparoscopy and robotics. Next slide. And to robotics. Here we see a patient who had a previous what's called a trauma laparotomy, or previous open operations. These are no longer contraindications. Even if you've had open operations, we can still do robotic approaches for cancer. And indeed, you can see there's an incision that's marked with a black marker on the patient. He had a big incision going all the way up and down. And on the right hand of the screen, you see those 3 little incisions, and that's all we needed to perform a major cancer operation on this patient. And again, by seeking out a board-certified colorectal surgeon who also has specific subspecialization in cancer outcomes, that allows you and your loved ones to get the outcomes that they really deserve. Next slide. Again, benefits of robotic surgery. We have the highest volume and robotic low anterior section of rectal cancer outcomes and also IBD surgery in the country using the robot. We have some of the lowest complication rates, less than 1%, a shorter length of stay, sometimes just overnight, if not less, lower pain, a quicker return to work, school, or activities. We do operate on young patients in high school and college who do develop colon and rectal cancer. Lower bowel frequency, meaning you don't have to go to the bathroom as often. And again, while maintaining great cancer outcomes, we also need to focus and emphasize improved quality of life and ability to enjoy life outcomes and events like weddings, graduations, etc. Next slide. Again, surgery at BMDA, what we focus on as your community cancer center affiliated with the #1 cancer program in the country. We do collaborate with our gastroenterology colleagues to individualize and personalize your treatment to each unique individual. If we can't do an endoscopic approach, we use combined robotic transanal approaches as well as incorporating certain types of chemotherapy and radiation therapy, in some cases being able to avoid surgery altogether for certain kinds of rectal cancer. And in fact, we're some of the leaders in Northeast Florida and South Georgia in this technique, in this practice pattern. And we like to make that available to all our patients. Next slide. Indeed, we have the highest rate of sphincter preservation in Northeast Florida with some of the lowest complication rates. We discussed how we also incorporate enhanced recovery after surgery, which allows patients to be better prepared going into surgery and better coming out of surgery with less pain and little to no narcotics post-operatively, with a quicker return to work and school, improved outcomes. And again, we like to emphasize the multimodality approach towards patients, including a non-operative management and or organ preservation in rectal cancer. Next slide, please. How do you prepare for surgery? We want to emphasize that you need to be nutritionally appropriate, maintain your protein intake, try to maintain an ideal body weight. We know that patients who have higher body weights have worse outcomes. So we try to emphasize and work together to improve your body weight and body composition, as well as diabetic control with your blood sugars and also smoking cessation. Next slide. Again, surgery at BMDA, multidisciplinary approach is paramount. You really need to seek experienced medical and surgical teams. We're one of only 45 centers in the United States and very few in Florida that's actually accredited by the Commission on Cancer for rectal cancer. So you should really pursue and seek out specialized care, not just the local surgeon. We emphasize robotics and minimally invasive approach with our goal to be individualized and personalized for both cure and improvement in quality of life. Next slide. Again, we're one of only 45 in the country and very few in the state of Florida and South and Georgia. And again, we have dedicated team focusing on not just colorectal disease, but colorectal cancer and malignant and pre-malignant diseases, incorporating a team of wonderful specialists, including pathology, gastroenterology, radiology, medical and radiation oncology, genetics, tumor registry, psychiatry, We have pelvic floor specialists, social workers as well. And we are leaders in clinical trials investigating new modalities for both diagnosis, treatment, and surveillance that may not be offered in other parts of not just Northeast Florida, South Georgia, but even the country. And we have some of the largest trial enrollment within the US. And again, we're one of the few that's actually accredited in the United States for rectal cancer. Next slide. So again, going back to my very first slide, see if you can try to avoid me. Try to avoid needing a colorectal surgeon. So please, even if you're not symptomatic, get screened. If you are symptomatic, don't blow it off. Not every rectal bleeding is just hemorrhoids. Please get screened. If you do get diagnosed, seek out a surgeon with high volume and specialty expertise. Robotics improves sphincter preservation. A multidisciplinary approach is critical and improves the ability to avoid a stoma, improve survival, improves quality of life. And in many cases, by combining a multidisciplinary approach, we're able to avoid surgery sometimes and get you to surveillance and long-term survival. And again, Baptist MD Anderson wants to be a partner with you and our community to offer the best and most contemporary and individualized care for you and your loved ones. Next slide. Thank you. This is our view of the world as colorectal surgeons. Next slide. Thank you.
Thank you very much, Dr. Landman, for your presentation, and certainly Dr. Goppel for your presentation earlier on what is colorectal cancer. And we've had a very interesting conversation about how do we treat it, what is it, how do we, where does it come from? And we have some very interesting questions from our audience that we would like to pose to the both of you. And I'm just going to jump right into the questions that we've been asked. And one is, what is the death rate from a colonoscopy procedure? Has anyone ever died as a result of having a colonoscopy? And this person says that they know at least 3 individuals who died a day after having a colonoscopy. And why does this happen? So either one of you who would like to address that, please feel free.
I could address that question. That's amazing that you know 3 people who've had colonoscopies and died. I don't know the circumstance to each of those, but the complication rate of a colonoscopy is very low. The risk of a perforation or some significant complication requiring hospitalization or surgery is less than 1 in 3,000 colonoscopies. So I can tell you, if that death rate was very high, we wouldn't be doing colonoscopies and they would not be considered FDA procedure. So I will, sorry, let me get back. The video is not working. So I would tell you that the risks are very low. Talk to your doctor about it. They can go into detail of the risks involved, but there are sedation risks. You also have to be screened to see if you're a good candidate for a colonoscopy. If you're morbidly obese, have a significant obstructive sleep apnea, have cardiac issues, you're probably not an ideal candidate for a colonoscopy and should look at other modalities.
Thank you very much, Dr. Gopal. We have another question. One of our guests said, my husband had 2 polyps removed 3 years ago at 81. Does he need to have another colonoscopy? If so, when should he have it?
So I'll take that question also, Ron. A colonoscopy should be continued on throughout life if you have a high functional status and if you also without no comorbidities. What happened is people stopped screening in the 60s and we were noticing more patients in their 80s and 90s getting colon cancer. So if you are healthy and you do not have many comorbidities, depending on the pathology of those polyps and size of those polyps, you should have a repeat colonoscopy in 3 to 5 years. And you could discuss that with your gastroenterologist by looking at the pathology, the size of the polyp, and looking at how your overall health is. If you're not doing very well and you have other issues, then I would not recommend further colon cancer screening.
Thank you, Dr. Gopal. Any suggestions for initiatives that the community can embrace to help reduce the disparities of colorectal cancer that either of you will recommend?
I'll give Dr. Gopal a little break. I think the number one thing to do is frankly talk to each other and get the word out. Most people are simply afraid of colonoscopies, afraid of the prep. However, if we can demonstrate that, hey, the prep is maybe the worst thing, but otherwise, like Dr. Gopal said, the complication rate is really low, and colonoscopy itself, especially screening colonoscopy, can be curative and avoid surgery and avoid progression to cancer. I think that needs to be particularly emphasized, particularly when, unfortunately, at this day and age still, because minority groups are getting screened less often than non-minority groups, their incidence rates and unfortunately mortality for colorectal cancer is much higher. So I think education needs to be emphasized more than anything else. I think Baptist, together with the Borland Groover group here, has done a wonderful job in trying to do outreach and education into the community. We've made it very easy to coordinate and get colonoscopies if patients want. They simply dial that 904-202-4U, and our operators are standing by, will help them coordinate that, getting a colonoscopy. Indeed, when we started this project and program last year, we were able to both significantly screen a lot of patients who otherwise would not have, but also detected multiple cancers that would not have been detected at earlier stages and treat them to improve their survival so they don't present at later stages. So screening in these programs and education really goes a long way to improving the health of your communities. Mm-hmm. And the more we get out there and educate our loved ones and our community members, the better we can improve their health.
Yeah, so for example, this webinar is something that we can use as an education tool. So our participants who are guests online who are watching this webinar right now will have the opportunity to share it with friends and family members in the community so that they can learn and get the same information that you've had a chance to get this evening. And Dr. Gopal, do you have any other suggestions about how we might, any initiatives that we may do in the community that might really help decrease the disparity as it relates to colorectal cancer? You're on mute, Dr. Gopal.
I definitely do agree with what Dr. Lamon said. Education is most important, and there's a lot of learning points if you can look at in communities, getting over myths and phobias, and building trust with communities to get people screened is very important. You can look at a lot of high-profile people have died of colon cancer recently. Chad Boseman of the Black Panther star, he died of colon cancer, and he did not educate his community or his friends and family that he had colon cancer. It would have been nice if we could have known about it earlier, and he could have been a spokesperson for people getting colonoscopies. But we ourselves as doctors, as hospital systems, as educators, community leaders need to discuss colonoscopies, preventing colon cancer, so that these patients don't have to see Dr. Lamb. He's a great guy, but we don't want to keep them out of the OR for surgery, and hopefully not ever have to deal with colon cancer.
Great. Thank you very much, Dr. Lamon.
Yeah, if I may, unfortunately, what we've realized is there's some stigma associated with talking about pooping and colonoscopies. And I think that's the biggest problem that's one of the other biggest problems. Listen, everybody's born with almost everybody's born with 2 arms and 2 legs, you know, and a colon and rectum. And everybody, just like that title of the books that we give to little kids, everybody poops. And unfortunately, if everybody poops, everybody's also at risk for developing colorectal cancer. There's no stigma, no shame to be had about getting a colonoscopy or even about getting colorectal cancer, okay? But at the same time, we have modalities like colonoscopy that can detect it, prevent it, and cure it before it becomes a problem. So to the converse of what Dr. Gopal said, he's a nicer guy. You should see him and his colleagues to prevent you from having to see people like me. You know, I think we can really improve our community's health by getting more people screened. And that's what we need to emphasize. There's no shame, nothing to be embarrassed about at all.
Yeah. So I have another question that is a little bit related to what you just shared, and that's in terms of being ashamed or not wanting to get a colonoscopy as it relates to fear of getting a colonoscopy. And this person asked, for people who fear colonoscopy, would a suggestion to carry or to try Cologuard be better than no screening at all, despite the lower sensitivity? Would you like to respond to that, Dr. Gopal?
So Cologuard has almost a 12 to 13% false negative and a false positive. So it is very good for picking up advanced cancer and disease. It is not a very good test of picking up on polyps at a lower degree and lower stage that do progress into colon cancer. So if the test comes back positive, guess what? You got to have a colonoscopy. And so you still have to take the PrEP, and that is the only way, the curative way of removing those polyps is with a colonoscopy. So if you're going to go through, you know, the process, might as well go through it right the first time instead of choosing a test. And we do see a lot of primary cares and other communities and even insurance companies promoting Cologuard. I think it's better than nothing. And so if you do not want to have a colonoscopy, realize it's not the greatest test, which is Cologuard, but then do something is better than nothing.
If I could add upon that, I think Dr. Gopal is correct. Cologuard is better than nothing. However, like he said, if they find something, the colonoscopy that is then performed with a positive Cologuard is then no longer screening colonoscopy, which adds cost. Additionally, Cologuard needs to be done every 3 years, whereas a colonoscopy, you only have to do it once every 10 years. So having said that, yes, I'm in favor of colonoscopy. Obviously, it is the gold standard. However, you know, if you're so adamant against it, and I'm still not sure why, because I'll tell you, you'll get some great sleep with the new medications like they give you for sedation. It's great, but something is better than nothing, and we'd still rather you get screened one way or another. However, we'd still like to emphasize that colonoscopy itself has been shown to actually be curative and improve survival. But something is better than nothing.
Yeah, I just thank you very much. Thank you both for that. I had a friend who watched this webinar on last year or saw the presentation that happened last year during Colon Cancer Month, who had used Cologuard a few months ahead in advance. And once he saw this webinar, he went and had a colonoscopy, and he had the colonoscopy and they found 15 polyps that the Cologuard did not detect at the time. So he called me to thank me for the webinar because had he not, things could have looked a little bit more, things could have looked differently for him in a few years when he was going to have another colonoscopy and do Cologuard again later. So good advice, and thank you very much. There is a question here for Dr. Landman. What are the risks or complications of robotic laparoscopic surgery? Is it possible to lacerate other organs during robotic surgery?
Sure, it's possible just like with open surgery. I think the risk is much lower, especially when performed in expert hands who do this hundreds of times a year, thousands and thousands over their career. But the risk should be about significantly less than 1%. The major risks of any operation, whether done open or robotic or laparoscopic, include bleeding, obviously you're doing an operation, infection or leak, because we are dealing with a colon, which is full of bacteria and stool. Leak is basically when we do the connection from two portions of the intestine. If the intestines don't heal 100%, they may leak something. Basically what we're doing is plumbing, in fact, sewage plumbing. However, though national rates of those complications are around 7 to 14%, I'm really happy to say that here at Baptist MD Anderson, our rate of complications is a lot less than 1%. I can't tell you it's zero, because if you operate enough, you're going to see issues. Just like if you do enough colonoscopies, you'll see some issues. But that really shouldn't deter anybody from having an operation that will cure their lives. I'll say that probably complication rates are much lower with robotics. So yeah.
Thank you, Dr. Landman. Dr. Gopal, there is a question about clarity for you. Can you please clarify? This participant thinks that they heard you say that if you have other health issues, you should discontinue colonoscopies. Can you please expound upon that, please?
So let's say you had a colonoscopy at age 75 or 80 and it was normal and recommended 10 years. And 10 years from now, if you were not doing very well, if you were wheelchair bound, or if you had significant heart failure, significant COPD, breathing issues, or you had other advanced cancers and other comorbidities and medical conditions, you probably need to focus on those acute medical problems instead of a colonoscopy at that juncture, because as any procedure, there are risks, and you usually want to deal with the problem of your health that is most pressing at that time. But if you are doing very well, everything's very well controlled, your heart disease is under control, your diabetes is under control, you have no significant heart or lung problems, then you can proceed with continuing on colon cancer screening and colon cancer surveillance.
Thank you very much, Dr. Gopal. Here is another question that either one of you can take. Do you perform a significant number of colonoscopies, I guess this is for Dr. Gopal, on Medicare beneficiaries taking advantage of the Medicare coverage of an initial preventive physical exam when done within 1 year are enrolling in Medicare? If not, is there a benefit to educate primary care physicians about the benefit when graduating their client on private insurance to Medicare?
I'm not as well versed in the payment process or the insurance and different plans. I know for most healthcare providers, they cover screening tests 100%. And I know Medicare also covers screening tests. So I don't know the logistics of transitioning from one insurance to the other, but I do know that screening tests are by most insurances 100% covered. So you'd have to talk to your insurance provider and your primary care to find out what's the right plan for your health.
Thank you very much, Dr. Gopal. We do have another question. What are some good food items, or what should people eat for a healthy colon?
I guess I'll take that. What we generally recommend is the same thing that our first grade and second grade teachers emphasized back in elementary school with that food pyramid. An emphasis on a high fiber diet with fresh fruits, vegetables, whole grains, brands, and also drinking a lot of water, about 8 to 10 glasses of water a day. I think the emphasis on getting a high fiber content in your diet, as well as water, has generally been shown to be both heart healthy and colon healthy as well. If it's difficult to get that fiber content with your diet, using a fiber supplement such as Metamucil, Benefiber, they make fiber gummies. Those also work. The goal is really to get about 20 to 30 grams of soluble fiber a day. So.
Good. Thank you, Dr. Landman. Dr. Landman, I have another question for you. When a person has a diagnosis of colorectal cancer, what type of doctor should be on the treatment team? Or is the surgeon enough? Or should there be other specialists working along with the surgeon to discuss treatment?
I think when you're first diagnosed with colon or rectal cancer, first seeking out a skilled and specialized board certified colon and rectal surgeon should be the #1 emphasis. That surgeon can then evaluate you, initiate the staging process. If it's a rectal cancer, will incorporate and involve a multidisciplinary team management with a tumor board approach, such as what we have here at Baptist MD Anderson. Most colon cancers, however, don't need the incorporation of a medical oncologist or a radiation oncologist because they don't need any additional treatment. So only post-operatively may they require you seeing those specialists. And again, that colorectal surgeon can involve those physicians and specialists as needed. Sometimes we'll refer to those specialists if there's a question of needing any additional treatment or surveillance. But I think getting a specialized board certified colon and rectal surgeon, it should be the emphasis. And they can then draw in, involve, and incorporate a multidisciplinary team if necessary.
Thank you. Thank you very much for that answer. We do have another question from our audience concerning thoracic aortic aneurysm. Is it a prohibitive condition for colonoscopy? I think that was that's related to the conditions that were asked about earlier, Dr. Gopal.
First, if you do have a thoracic, well, actually abdominal aortic aneurysm or thoracic, hopefully seeing a vascular surgeon and finding out what their recommendations are. First of all, I would have you go see a thoracic or vascular surgeon to understand, is it, how large is it? How many centimeters is it? Is it a risk of a rupture? Is there a leakage? Has it been repaired? So you would have to get clearance from a vascular surgeon before coming to see a gastroenterologist for colonoscopy. There is risk, there's increased intra-abdominal pressure, and we don't want to cause any complications. So if you do have an established aneurysm, we would want you to get clearance. Just as we would for a patient who has cardiac issues, we'd have you get cardiac clearance from your cardiologist and the same from your pulmonologist before we put you under for a procedure.
Thank you. So this question from our audience has to do with staging of the cancers. So staging provides important information about the extent of cancer in the body. Is stage 3, when you're diagnosed as stage 3, is the prognosis low or is it still considered to be good?
So let me take a step backwards. Usually most colon and rectal cancers are staged 1 through 4. Staging usually is based on combinations of endoscopy, CAT scans, in some cases MRIs as well. And we incorporate all of that together with a pathology to come to a stage either preoperatively in the setting of rectal cancer or postoperatively for most colon cancers, based on the pathology as well. Traditionally, most patients who thought they had stage 4 disease, meaning they had metastatic disease, thought they have a death sentence. Fortunately, I should say, fortunately, in many cases with isolated metastatic disease, we're still able to offer and provide a multidisciplinary approach to management where patients can have excellent outcomes long-term. So even stage 4 is no longer a death sentence. Stage 3 disease means that the tumor has begun to spread to the lymph nodes around that portion of the colon and rectum. We have excellent outcomes for patients with stage 3 disease. They're much better than they were even 5 years ago, and definitely 10 and 20 years ago. Again, it does require combinations of medical and surgical and sometimes radiation approaches if it involves rectal cancer. But no, patients still can have really good life expectancies with good quality of life, even if they do have stage 3 disease. The chemotherapy and radiation therapy that we have based on the diagnosis, as well as surgical modalities, are much more advanced than they used to be, with far fewer side effects. And even if they do have side effects, we have actually better drugs for those side effects now. So I wouldn't, put the fear of getting diagnosed with stage 3 disease to be in the forefront to prevent you from getting treatment. We have excellent treatment now for stage 1, 2, 3, and even 4 disease.
Thank you very much, Dr. Landman. And thank you, Dr. Gopal. Our time is far spent, and we really do appreciate the answers that you gave to the questions of our audience, because we know there are many people out there who have fears about getting a colonoscopy. We also realize that there are people out there who are listening to others as opposed to listening to the professionals like yourselves, and is taking advantage of getting these screenings, which can certainly save their lives. And I am getting colonoscopies and getting screened for colorectal cancer is very near and dear to my heart and my family's heart. My younger brother was diagnosed with colon cancer at the age of 43 and passed away at the age of 46. And he had symptoms, but because he was not 50, he did not get a colonoscopy, and nor did his physicians recommend a colonoscopy. So one thing for sure, we have to learn to be advocates for health advocates for ourselves, and move forward with things that may not always seem like it makes sense because we don't fit the age requirement. So we want to thank you all so much for being here this evening. If you need to get a colonoscopy, if you're 45 years old or older and you need to have a colonoscopy, please just call 202 for you to get scheduled for a colonoscopy. Don't hesitate and don't wait for that. If you have not had a colonoscopy in the last 10 years, please make sure that you do. Also, please make sure that you speak with your physician, your primary care physician, about getting one. Just remember that you have to trust your gut. Trust your gut and put your fears behind you. The fears are minimal, considering what could possibly happen with a diagnosis of colorectal cancer. So get screened, and I cannot say it enough for all of you all to get screened if you meet the criteria. There is no reason why you shouldn't get screened and have a colonoscopy done if you are 45 years old or older. So we want to encourage those people who are in your sphere of influence, your relatives, your mother, father, grandparents, and even children at this point, to get screened. It is so important. This campaign for the month of March, April into May is so that we can scream to the top of our voices how important it is for everyone who fit the criteria to get screened. So call 202 for you and schedule an appointment for your colonoscopy today. Thank you, everyone. Thank you for your time. There is a link in the chat section. If you have not already clicked onto that link to complete the survey about this evening's presentation, we would appreciate it if you did. We also will be sending that link to you in your email, along with a link to the recording. So please complete the survey. That's really important to us. And please share the recording with others as when you receive it. So thank you very much. And again, have a wonderful evening. Good night.